Okay, guys, welcome back. We're going to go into hypovolemic shock. This is by far the easiest shock to kind of understand. This is basically an inadequate amount of fluid and or volume in the circulatory system. We are losing fluid out of our circulatory system, okay? Usually this is hemorrhagic causes, but it can also be non-hemorrhagic causes. We're going to get there in a minute. This occurs with severe thermal burns. Okay, you guys can technically go into a hypervolemic shock from too bad a sunburn. Okay, we'll talk about that as we kind of go through this lecture. So, dehydration, the loss of water or fluid from body tissues, can cause or aggravate shock. Okay. We can also start going into a hypovolemic shock if we are vomiting too much or if we have too much diarrhea. Okay? And again, I'm going to repeat this for you guys. This is the third time I'm going through this. All right? But remember your acid-base balance. We can live in an acidic state longer than we can live in a basic state. Right? Your normal pH is at 7.35 to 7.45, right? And we technically live in that state, maybe kind of jumping outside the boundaries a little bit here and there, but really we're in between that 7.35 and 7.45, okay? Remember that you can live in an acidic state longer. An acidic state is below 7.35, then you can live in a basic state, which is higher than 7.45. If I have diarrhea, remember, diarrhea is base out the butt, okay? If I am losing base out the butt, if I have severe diarrhea, I am becoming more acidic. Yes, that is a life threat. However, it's not as big as life threat as vomiting, okay? If I am vomiting, I am throwing up my stomach acid. My stomach acid is some of the strongest acid on the face of the planet. It's not the strongest, but it's up there. Okay, it can compete, trust me. All right, if I'm losing that acid, right, from vomiting for days and days, I can't keep anything down, right? You guys are trying to do a specific diets, right? Bananas, rice, apples, tomatoes, whatever the hell it is, right? And you guys just keep vomiting and vomiting and vomiting and vomiting. You are losing acid, which means you are becoming more basic. Okay, we can't live as long as we can in an acidic state from a basic state. Okay, so vomiting, when questioned, vomiting is more of a life threat than diarrhea, but they are both life threats. Okay, we got to fix that, and we are losing massive amounts of fluid. If we are losing those massive amounts of fluid, we can go into a hypovolemic state. Okay, here it is, loss of fluid. It could be because of dehydration. It could be because of leaky capillaries, such as some of the disease processes that we talked about, or the other forms of shock that we have talked about, specifically your anaphylaxis or your septic shock. Burns, right? Significant burns can lead to hypovolemic shock. And any time that we are hemorrhaging, whether it's externally or internally, if we are losing fluid out of the cardiovascular system, we are in a hypovolemic shock. So as you can see from this, we have a problem with the fluids. Our pump is good, our pipes are good, but our fluid is not contained where it's supposed to be. All right, and I've talked about this before. When you guys are unable to explain the signs and symptoms of shock in your patients, right? They are bleeding internally. It is hypovolemic shock until proven otherwise. They are bleeding internally until proven otherwise. Okay, we're going to talk about this a little bit more when we get to trauma, but just for right now, remember that hypovolemic shock is just a loss of fluids. It's not a pipe problem. It's not a pump problem. It's a fluid problem. We're losing fluids. Every red blood cell counts. Blood on the ground means that blood is not in the patient. That blood is not in the patient. That blood is not able to be utilized for oxygen transportation and gas exchange. Okay? We want to make sure that if we are seeing a patient actually losing blood, we need to stop this bleed if we are able to. If we have any signs and symptoms of shock, and we are unable to explain it based on the patient history, based on the events leading up to the 911 call. These people are bleeding internally until proven otherwise. It is time to rock and roll. We got to go. We got to get them to definitive care. More than likely, we need to get them to the surgical table, or at least some place where we can start doing fluid resuscitation in order to benefit our patients. The most common shock you guys are going to see is hypovolemia. Okay? And again, this doesn't have to be traumatic, guys. Okay? This could be because their electrolytes are off. This could be because that little old grandma just likes her Dr. Pepper and she doesn't like to drink water, right? This could be because they're bleeding externally or bleeding internally. This could be because they've been vomiting and not being able to keep anything down for the last 5 or 6 days, or they've been suffering diarrhea for the past couple weeks, or anything like that. Okay? Any signs and symptoms shock, okay, are assumed to be hypovolemic until proven otherwise. Okay? Any unexplained signs and symptoms of shock are assumed to be hypovolemic shock until proven otherwise. Please, please, please remember that, guys. Okay, here's a slide that was put together for you guys to kind of put a visual on everything myself. I'm a visual learner and an audio learner, so hopefully you guys are benefiting from all these lectures I'm doing for you. All right, so you guys can see that volume shock, also known as hypovolemic. Oh, there it is, redistributive shock. That's why I knew I put it somewhere for you guys. I knew it. Remember that redistributive shock is the exact same thing as distributive shock. They're just kind of used interchangeably. That's a container problem, right? Our pipes are too big. We have the same amount of fluid. We're not losing any fluid. Our pump's working okay, but our pipes are too big in order to create an adequate pressure for gas exchange. And then we have cardiogenic shock, which is also kind of around the same lines of obstructive shock. Eventually, they're both going to lead to a pump failure problem. All right, so the progression of shock can be slow. It can be quick. It depends on what type of shock we're dealing with. It depends on the comorbidities of the patients, the age of the patients. It could even depend on the sex of our patient. Okay. However, when we're talking about the difference between compensated and decompensated shock, compensated is an early stage when the body can still compensate for blood loss or fluid loss or the vasodilation, or even possibly just the fact that your heart's kind of pumping irregularly, kind of leading to that pump failure. Your body is still compensating. Your body is fighting to stay alive. That's what it comes down to, okay? Decompensated shock is the late stage when the blood pressure starts to fall. The only vital sign that you're going to see differently between compensated shock and decompensated shock is when the patient's blood pressure begins to fall. So you guys show up on scene. This patient is a little anxious. They're cool, clammy, they're pale. You guys take a blood pressure and it's 130/80, okay? The patient starts becoming more and more confused, even though you have them on some oxygen, even though you're trying to keep them warm, even though the story just isn't adding up to what the events that are leading up to the call based on what you are seeing on the patient. And you guys check the blood pressure again, and that blood pressure is now 100/70. Boom! Decompensated shock, okay? Their blood pressure has dropped. They have now entered decompensated shock. They are giving up the fight, people. Okay? Their body's getting tired. Their body's running out of energy. Okay? You are actively watching this patient die right in front of you. Okay? We're going to talk about this some more. All right? Once we kind of start getting those drops in blood pressures, depending on how far these blood pressures kind of go, depending on how far or how much fluid we actually use, the effects can be irreversible. unfortunately, where our patient's going to, if they do survive, they're going to have some kind of deficit because of the shocky state that they were in. We must, as medical professionals, as EMTs, this is one of our enemies, right? This is one of our enemies. We need to be able to see this enemy quick in order to attack, okay? We must be able to recognize the signs and symptoms and start our treatment for shock early in the process of the time that we are with our patients. Okay, guys, jumped ahead a slide again, okay? Oh, I'm sorry, I did not jump ahead a slide. I want you guys to make sure that you look at this in your chapter, table 12-3, okay? I think this breaks down a very good, detailed what people will present like in a compensated shock compared to a decompensated shock. And I want you guys to really specifically see that the first bullet point of decompensated shock is a falling blood pressure. Okay? As soon as your patient's blood pressure starts to drop, they are starting to decompensate. Okay? We have gone from a compensated shock to a decompensated shock the second the patient's blood pressure starts to drop. So what does this mean to you guys? You have to reassess your patients. One set of vital signs does not work. Okay? We're talking repeats at least, at a minimum, every 5 minutes. Okay? Checking to see where that blood pressure is. Checking to see where that blood pressure is. Specifically, you guys going into intermediate and paramedic, where you guys can do fluid resuscitation, where you guys can actually start giving them fluids in order to help bring their blood pressure back up. We have got to be able to monitor these patients' blood pressures over and over and over again. When it comes to shock, blood pressure is by far the most important vital sign that we are going to get. Okay? The other thing that you guys are going to see, that if our blood pressure is dropping, what's happening to our mentation? More than likely it's declining, right? Because as our blood pressure drops, we are not perfusing our brain accordingly. And if it gets down too much, our brain's going to stop functioning and our patient's going to die, in which case you guys are then working a code. Okay, guys, so again, blood pressure is usually the last measurable factor to change in shock, okay? And it's really the biggest change that we're going to see because, again, that really kind of separates compensated from decompensated shock from us. When a drop in blood pressure is evident, shock is well developed, okay? We are starting to kind of go into irreversible damage from the shock that the patient is experiencing. This is very true in infants and children, okay? Kids are resilient. Kids are extremely good at compensation. But when we start seeing drops in blood pressure on our kiddos, when they are possibly in a shocky state, man, that is a very bad sign. We are way behind the 8 ball. And more than likely, we are going to have a very bad outcome for that infant or child, okay? And always have shock on your back burner. Anything and everything can lead to a shocky state, okay? We want to make sure that we are fully assessing our patients, that we are doing a full set of vital signs, all right, that we are monitoring those vital signs and reassessing often, making sure we're intervening when we need to, and really thinking about making sure that we are getting the patient proper tools or taking them to places with the proper tools in order to help them out as best as we can. Always, always, always expect shock in any patient. Okay, guys? Always expect shock in any patient. However, there are some conditions that will really point us to the right direction and where we have to move up shock to the front burners instead of the back burners when we have multiple severe fractures. Okay, bilateral femur fractures, femur and pelvis and humerus, right? It could be possibly where they have broken their whole arm, right? They've broken the humerus, they've broken the radius ulna, numerous fractures or fractures in the fingers. I mean, this can all lead to some kind of shocky state. Any injuries to the abdomen or chest, any injuries to the spinal column, if we are dealing with a severe infection or a patient that's running a high fever for sure, we're going to think about shock. Any kind of major heart attacks, and of course anaphylaxis, which is shock for the allergic reaction. Okay, this is a great slide for you guys. Please make sure you guys are starting to study this and look over this and seeing if you can explain yourself the pathophysiology behind beginning, middle, and end stages of shock. Okay, when we are in the beginning of stages of shock, our heart rate might be a little high. Our blood pressure can be completely normal. We're compensating, right? We're compensating. Our ventilatory rate is always usually going to match our heart rate, right? However, really, the only way that we can tell if the patient is truly in a beginning of shock is by the level of consciousness. And it's anxious. Now, let me tell you something. We do very well at making our patients anxious. The last thing your patient thought that they were going to do today is meet us, right? We are not on everybody's schedule. We are not in everybody's game plan, and we can make people anxious, all right? This is why this is very important for you guys to be sure to reassess your patient often, okay? Once we get into kind of the middle stages of the shock, our heart rate's going to continue to go up. It's getting faster and faster and faster. It means we're using energy, and our blood pressure drops. We are now in decompensated shock. Our blood pressure is dropping. Okay, ventilatory rate's going to match our heart rate. This is where the patient's really going to start becoming confused, irritable, and possibly combative with their mentation. And by the end, their heart rate's through the roof, their blood pressure's in the toilet, their ventilatory rate's basically matching their heart rate as best as it can, and they are completely 100% unconscious. This is not good. So we want to try to stop shock right at the beginning, and make sure that we're doing a good history on our patients, make sure that we're finding out what events actually led up to them calling 911, and making sure that we can make sense of all this based on how the patient is presenting. And this takes time, guys. Okay? I am definitely not going to be able to teach you this in class. This is something that you guys are going to have to go out into the world and just kind of experience. Okay? And you guys will be more than likely in our system, more than likely you will not be working by yourselves or with another basic. You'll be working with a medic or an intermediate, and you guys will have to use them as a tool, use them as a learning tool. Okay, have that discussion with your partners, right? Have that discussion. Man, you know what? I was going down this route, and you just took a left turn and went down this route. Why is that? What are you suspecting? You know, what do you think was going on with the patient? Try to use them as a learning opportunity in order to better your skills and better your knowledge of patient presentations. Okay, a couple of patient populations that we need to be concerned with, specifically with shock, are the young and the old. Very young patients, they don't have as much circulating blood volume as us healthy, normal adults, right? Very little blood loss can have some serious consequences for our younger people, okay? You can see liters of blood on the floor with an adult, but if we see liters of blood on the floor with the kiddo, that kid's in big trouble, okay? When we're talking about old patients, they have aging systems, right? Their cardiovascular system is not as strong as it used to be, right? They have comorbidities. They have other problems, health problems going on with them that can affect how they compensate to shock, all right? And if they're even able to compensate at all, okay, based on their medical history and their age and, things that might have happened to them, events that might have happened to them in the past with comorbidities. So keep in mind that young and old, they are the most susceptible patients out there, and not just to shock, but to everything, basically. And it all just kind of depends on the patient themselves, and what kind of health conditions do they already have to see if they're going to be able to compensate or not.